So thank you everyone for coming here. This is a very interesting and very important study that we are presenting here today. It's a kickoff for 1806, which has developed over the last 2 years of very hard work from Intergroup investigators from ECOG, Alliance, SWOG, negotiating with FDA regarding the endpoints, and we have come around with this now study, which will hopefully start by December this year. This is a kickoff. It's a registration trial, so I do request everybody to sign in. This will be recorded as your attendance for this trial. And then we'll be recording this meeting, and then we'll be sharing it on the SWOG website, so then the sites which are opening the trials can then go through the training and then document that they have done so. So we'll move forward with the trial. So this is a phase 3 trial of concurrent chemoradiation with or without atezolizumab for localized muscle-invasive bladder cancer. The agenda today is to have introduction, some protocol review, which will include study objectives, inclusions, exclusion criteria, enrollment goals, visit schedule, study procedures, radiation therapy, translational medicine and biobanking, patient perspective, monitoring and auditing, and investigator responsibilities, and Q&A after that. I have with me today myself from Mayo Clinic. I'm a medical oncologist. Josh Meek, who's not here, he couldn't excuse himself from his clinic today. He's here in Chicago. He's leading our TM from SWOG side. Dr. Jawar is a radiation oncologist. Dr. Gupta again is not here. He's a urologist who's leading the QOL from SWOG. And Melissa Pletz from the SWOG operations office is here with me. So the Dr. Lerner is our urology lead from SWOG on this protocol, with me and Samir from medical oncology and radiation oncology. Our protocol coordinator will be Gretchen. And biostats on the clinical side is being led by Dr. Tangen. Joe Unger is leading the quality of life section, and Melissa is on the biostats review also. Data coordinator is Joseph Sanchez. And we have extensive team from NRG, ECOG, Alliance, and CCTG, which have buy-in. We have the NRG lead as a study chair, Dr. Jason Efsasio. He's at MGH, and he'll be leading the radiation piece. And from ECOG, we have Dr. Han, who is also the ECOG study chair for urology for GU, and Dr. Brian Costello from Alliance with Jonathan Rosenberg. They are leading from Alliance. And Dr. Sridhar from CCTG, she'll be leading the efforts in Canada. So our TM portion, as I said, Josh Meeks, he's leading the SWOG side. NRG is being led by Dr. Feng. ECOG, Dr. Grievous. Alliance, Dr. Faltus. And QOL team, Dr. Gupta, Chen, and Dr. Morgan's here. So we'll start with the background of the study. We understand that around 28,000 new patients which are muscle invasive, only around 50% of them will receive aggressive therapy, which is essentially the standard of care, which is chemotherapy followed by radical cystectomy or definitive chemoradiation therapy for their bladder cancer. This is from NCDB. We know that the standard of care is neoadjuvant chemotherapy, which is cisplatin-based, not platinum-based chemotherapy followed by radical cystectomy from the SWOG trial. And the recently collected data from S1011, we know that only 45% patients receive neoadjuvant chemotherapy, and this is a study looking at radical cystectomy, doing extended versus limited lymph node dissection. And so we had very clean data, a SWOG study on academic centers. We still have only 45% patients receiving neoadjuvant chemotherapy. So there is a big gap. 55% patients are not receiving aggressive definitive treatment for their bladder cancer, and we need to bring change. And AUA and ASCO and NCCN, they have updated their guidelines, and they are recommending bladder preservation using trimodality therapy as an option for patients who are refusing radical cystectomy or are ineligible for radical cystectomy or are asking for bladder preservation, understanding the risks and benefits. And this could be the patient population who are not eligible for cisplatin or are not receiving platinum-based chemotherapy, which are the 55% patients who are going through the radical cystectomy without getting neoadjuvant chemotherapy. And so where is chemoradiation for bladder cancer right now? We have extensive data, although small subsets from the American trials, and the largest trial coming from UK, which shows that it is a good alternative with long-term outcomes approaching what is observed in chemo followed by surgical clinical trials. But still, at the outcome of 5 years of 52% OS, there is still room for improvement. We can improve this. And maybe that improvement will help us make this option as more frontline in the care of the patients and provide options, especially for the patients who now we have more and more elderly patients getting bladder cancer, and that option will be open for them. And so we came around with this with concept, and we decided we wanted to explore options where we can improve the outcomes of chemoradiation. And what we figured that immunotherapy is already approved in locally advanced and metastatic bladder cancer. And we knew that radiation is upregulating the expression of PD-L1 in tumor cells in dose-dependent fashion. And there is recent insight from the clinical trials of Keytruda and atezolizumab that PD-L1 expression does have some role in the response. And patients who have higher expression are the ones which are predominantly the responders. Although we see that patients who don't have expression, they also respond, but we clearly see that split there. And so if radiation is helping improve the expression of PD-L1 in the tumor cells, it may also improve the response rate to immunotherapy. And we have already seen that the combination of chemo and immunotherapy is approved in lung cancer and is very close to, and data from recent Genentech-led trials were presented in the lung meeting late last month, which showed that combining chemo radiation in lung cancer, they have not seen any excessive toxicity, and the trial is moving forward for full enrollment, suggesting that this modality of combining immunoradiation chemotherapy may be a good option and probably safe to investigate. And fortunately, when we were developing this trial, there were already small phase 2 trials opening up in different institutions at ISTs, especially in New York, Australia, and UK, in Europe, that we realized that by the time we will mature this trial and start up and running, we'll have some data from these small phase 2 trials regarding safety. And that's what we saw. We reached out to the investigators, and we found no extra toxicity, bladder or bowel, in concurrent chemoradiation with immunotherapy in the patients who were already enrolled on these trials. And most of the patients have completed, who were enrolled have completed their designated therapy, are in follow-up. And so based on that, the CTEP asked us to proceed with a phase 3 design, not just start again from the scratch of doing a phase 1 and 2 study. We have built this trial as a phase 3 registration trial with a safety run-in, and we'll also keep asking for data from already ongoing phase 2 trials by other institutions. So the hypothesis is that checkpoint inhibitors will improve the efficacy of concurrent chemoradiation for localized bladder cancer. And study schema is very simple. We realize that in a cooperative group setting, if we add too many nuances, it is going to cause us hurdles and more ineligibility, as we saw in 1605. So we did a lot of brainstorming designing this trial to be as pragmatic and as open as possible for any clinical trial ever in this space. There has not been a trial which is as open in the eligibility in bladder cancer, in bladder preservation, the way this trial has been designed. This patients who have disease T2 to T4, N0, will be stratified based on the chemotherapy regimen which we are opting for, radiation field, performance status, and clinical stage, and will be randomized in 1:1 fashion. They will receive either chemoradiation, which will be physician choice chemoradiation. Physicians can choose what chemoradiation regimen they want to use. We are giving them 3 big options: gemcitabine alone, cisplatin alone, 5-FU-mitomycin. And they can use any of these options versus all they need to do is add atezolizumab 9 infusions on the other arm. So it's a very simple treatment design. I'm going to talk more about how simple the eligibility is in the subsequent slides. And we will be looking at endpoints. The primary endpoint is bladder intact, event-free survival. Now, this is a registration trial without a overall survival endpoint. And we went through a lot of discussions within the cooperative groups and with CTEP and FDA to reach to this, that FDA agreed that they'll consider this endpoint as a registration endpoint because this endpoint is clinically relevant. This endpoint includes not only recurrences in the bladder, in the lymph nodes, or systemic recurrence on follow-up. It includes death from any cause. It also includes radical cystectomy without having cancer. What if we cause patient toxicity with this regimen and patient ends up losing their bladder? And if that happens, we are losing the primary aim of this treatment modality, which is bladder preservation. And so we felt this endpoint has to be critical part of the endpoint from a patient's point of view. If the patient has lost their bladder, then we have lost our purpose of this treatment modality. And so since we added this endpoint where the patient doesn't have cancer and they have not died from anything, but they have lost their bladder, it became an event-free survival endpoint. We will be having overall survival as a secondary endpoint, in addition to the disease-specific and metastases-free, also looking at non-muscle invasive recurrences, quality of life, and TM portions. So we'll go over the key eligibility criteria. We have allowed every histology to go on to the study except the small cell. If the patient has even a small component of small cell in the biopsy, they cannot go on to the trial. But if you have sarcomatoid component, you have adeno component, you have squamous cell component, you have some other component, as long as you have urothelial carcinoma in the report, the patient can go on to the study. Patients, this is written in the eligibility, patients must undergo pelvic exam under anesthesia. The findings and clinical stage to be recorded in the operative report. But we are going to see how we can word this as a form addition. I have to talk again with Melissa about this, but I looked into the data of S1011. Around 50% patients are being reported as their pelvic exam done even on 1011. So we'll have to see if we want to put this in the eligibility, but it's there for now because we wanted to have the clinical stage, whether the patient's bladder is moving by manual examination, because if not so, then the patient is T4B, and we don't want those patients to go on the trial. These patients can have TURBT within 70 days of randomization. So you saw that 1605, we had a 60-day window, which was causing some problems with eligibility. So we extended that to 70 days so that the patient have another 10 days to go on to this trial without having another TURBT. Patients with unilateral hydronephrosis are eligible if their kidney function permits enrollment on the study. All previous trials, hydronephrosis was an exclusion. We felt that patients who have this disease, most of these patients, even with intravesicular tumors could have, or polyps can block the ureter and cause hydro. As long as the kidney function is intact and the patients can receive designated therapy, they can receive concurrent chemoradiation on this trial. But if they have bilateral hydronephrosis, then we are asking you not to enroll those patients since the cisplatin is an option. So we were worried if the kidney function may get compromised if they have both kidneys obstructed. We have allowed the performance status of up to 2, which truly reflects this population of old men who have bladder cancer to go on to this study. We are allowing GFR of more than 25 ml per minute, but especially we are putting a caution there that physicians should not opt for cisplatin if their GFR is less than 50. There's a guidance there, but we are otherwise allowing patients up to GFR of 25 to go onto the trial, and hemoglobin of 9. We are going to allow patients with HIV, HBV, and HCV to go onto the trial as long as they meet certain criteria which are defined in the protocol with their CD4 counts and their viral DNA titers. They are not being excluded from the study. We are going to allow malignancy outside 2 years. So as long as patients had any cancer and they had cancer-free for 2 years, which is again very unusual. Most of the trials will have 5-year window. Well, we thought that these are old patients and they may have other malignancies in their history, and that they will be excluded from this trial. So we have reduced that window down to 2 years. And patients with hydronephrosis, as I said, as long as they meet, they will be able to go on to the study. And again, as long as the patients not have urothelial cancer outside the bladder, they will be eligible. But if they have urothelial carcinoma of the upper tract and they had definitive treatment with nephroureterectomy, they will be able to go on to this study. Let's see. So important exclusions. Diffuse CIS is an important exclusion. From the experience from our NRG previous trials, the carcinoma in situ doesn't respond to, and these patients may continue to have repeated CIS after chemoradiation. And if they are starting with diffuse CIS, these patients may end up getting radical cystectomy for high-grade non-muscle invasive disease after treatment. And so we felt that patients who have clearly diffuse CIS should not be enrolled onto the trial. As I said before, urothelial carcinoma at any site outside the urinary bladder within previous 2 years is an exclusion, except T1 CIS of the upper tract if they had nephroureterectomy. If they had prior pelvic radiation for any reason, cervical cancer or any other reason, prostate cancer, then these patients cannot go on to this trial. So patients who develop radiation-induced bladder cancer from prostate radiation, they cannot go on to this trial, even if they are in remission. If they had prior muscle-invasive bladder cancer in history and they are in remission because the physician did, so many patients with bladder cancer, they only get TURBT in our clinical practice, and their bladders may not show any disease anymore. And once they have recurrence, and then once this trial is available, they may want the patient to go on to that trial. Those patients will not be enrolled on this trial. Received any systemic therapy for non-muscle invasive disease. So if they have received immunotherapy, like they have been on 1605 and now they have muscle invasive disease, then they cannot go on to this trial. Patients who are on 1602, they are progressing, they can go on to 1605. But patients progressing on 1605 cannot go on to this trial. This is very important. Standard exclusions for immune checkpoint inhibitors. You all have experience with immune checkpoint inhibitors. There is a standard list of exclusions of autoimmune disease that is same. We have just copied it from the previous trials. It stays the same. As long as patients is on immunosuppression, prednisone more than 10 milligrams, those patients, all those standard exclusions exist for any immune therapy trial are there. But in general, disease-specific eligibility criteria is very pragmatic, very open to help patients get onto this trial. So I'm going to give the mic to Melissa to take over the statistical design and enrollment goals. Thank you.
Thank you.
All right, so I'm going to talk about statistical design and enrollment goals, but I'm probably going to go a little bit fast through that because not that statistics aren't super cool, but the interesting stuff is the study visits and data submission. So as Dr. Singh said before, our primary endpoint is bladder intact event-free survival. All of the events that qualify for that endpoint are muscle-invasive bladder cancer, clinical evidence of nodal or metastatic disease, radical cystectomy, or death due to any cause. We have a long list of key secondary endpoints as well, including that overall survival endpoint. We also have a modified bladder intact event-free survival, which instead of just death due to any cause. It's death within the first 90 days of receiving protocol treatment. And we also have biopsy response at 18 weeks, and you'll see that in our study visit schedule in a few slides here. And that will require a required biopsy at that 18-week assessment time point. We have 4 stratification factors in this study. Clinical stage, your intended chemotherapy regimen that you will specify at randomization, the radiation field, and performance status. Statistical design, we're looking for a 12% improvement, 85% power, one-sided alpha of 0.025. We're randomizing in a 1-to-1 ratio between the 2 arms of chemoradiation versus chemoradiation plus atezo. The total sample size we're looking for is 475 patients. It will take us about 4 years to accrue to this study if we get 8 to 12 patients a month. And we're anticipating an additional 3 years of follow-up after we reach our enrollment goal to have enough events to analyze the primary endpoint. But of course, that totally is determined by how fast our events come in. We will have 4 formal interim analyses to test efficacy and futility. They'll be approximately at 3, 4, 5, and 6 years after the first patient is randomized, but again, completely determined by the number of observed BIEFS events that come in. So now data submission and study visit schedule. So prior to registration, because this is an FDA registration trial, there's this eligibility criteria form. If you have 1605 open at your site, you probably know what this looks like. But we are going to need this completed, signed and dated by the registering investigator. The paper copy is going to need to be signed and dated, and the date needs to be after the patient has consented, but prior to registration. That's what the auditors will be looking for, and FDA auditors if it ends up going to the FDA. You will also need to scan in this paper form as a baseline source document in RAVE, as you would path reports or op reports. And you will also need to enter these answers electronically in RAVE, and that has to do with the data format that we have to submit to the FDA. If your patient, for some reason, an eligibility criteria is not met and you find out later, we actually need to document that electronically in a database format. So that's the reason why we also need electronically in RAVE. It seems like overkill, but there's a really good reason for each one of these points. This is perhaps, in my opinion, the most important slide I have. So this is, if you're going to get this trial started at your site, this is the slide you need to photograph. There are 2 registration steps. First, you register the patient. If this is the first patient at your site to receive either 3D CRT or IMRT, then before randomizing that patient, you need to submit your pre-RT planning documents via Triad within 3 days of that initial registration. And we have folks at IROC who are going to review those plans and give you an approval, I think within 48 hours or something, a very short timeline. And they will give you your approval to then randomize to step 2. If this is not your first patient to receive one of those modalities, you will just continue on to step 2 randomization on the same day that you register that patient to step 1. You are still required to submit those RT plans, but you can start your treatment before you submit them. You just have to submit your RT plans via Triad within 7 days after you start that RT.
Melissa?
Yes, sir.
What do you mean by first patient at site? I mean, all of us do radiotherapy.
On this trial.
On this trial.
Registering to this trial.
That's very important. You gotta put
Oh.
that in there.
I think it's better in the protocol than it is on my slide. I guarantee it.
But it doesn't.
I will modify the slide.
Clear.
The first patient that you enroll on this
First enrollment
trial
at site.
to receive it. So if you register a patient and your intent is to do IMRT and you submit your plans and they're for some reason not approved, you have another patient that comes through in the registration process, and you also want to give that patient IMRT, you haven't had a plan yet that has been approved, you haven't had a patient that is actually that is randomized and started, then that second patient you would still need to submit before randomization. So it's more of a, you have to get the approval for that first patient registered with that modality and get them started before that requirement goes away, if that makes sense. Sorry for the confusion. And so I wanted to mention, this is a kind of a screenshot of part of the study calendar that you'll see in the protocol. So since there's 3 different options for your chemotherapy, and they all have kind of different, what you would consider a cycle perhaps, we are defining in this trial a cycle to be 21 days. So and that's the time period for which we're going to report cycle-specific toxicities to the NCI. That's mostly the reason why we need to define what a cycle is. So it's going to be 21 days, and it kind of matches up with if you're on the atezolizumab arm, it's 1 dose of atezolizumab. And that's pretty defined in the protocol. And this is just the rest of that study calendar. I didn't want to leave them out. And I wanted to mention that atezolizumab, if you're on that arm, does continue past that 7-week time point, but the chemoradiation should be wrapped up by that 7-week time point. And this is that disease assessment schedule, which I believe Dr. Singh is going to go into a little bit more detail, starting at week 18. So you will be done with your chemo and radiation by that point. Starting at week 18, following randomization, right? So that second registration step, following randomization, that is your starting point for counting. You get a cystoscopy and urine cytology every 12 weeks for the first 2 years, and then every 6 months for years 3 through 5. 5 years is the maximum follow-up on this study for patients. And then I mentioned that mandatory biopsy at week 18, and that's for that key secondary endpoint that I was telling you about earlier. And the window for that assessment is plus or minus 14 days. And you will need to submit the tissue from that mandatory 18-week biopsy for central path review, and that's a requirement, regardless of if the patient consented to the translational medicine specimen submission. This part is for central path review and will be required. And CT MRI scans will be every 12 weeks for the first year, every 6 months for years 2 through 3, and then every 12 months for years 4 through 5. And in the same way that you're submitting those RT plan materials, you will need to submit the scan images via Triad also. We'll still need those CT MRI reports scanned in as source documents in RAVE, but we need the actual images uploaded via Triad. And so here's kind of a visual representation of all those words that I just said. This is a study calendar also from the protocol that you will see. And I highlighted that week 18 mark just to really stress that we need that biopsy, and to also stress that we need that tissue from that biopsy, and we need all of the images submitted via Triad. We also have quality of life in this study, which is going to be a really important aspect, I think, right, of bladder sparing. We have 4 questionnaires that will be asked at baseline and then at 5 follow-up time points. We also have somewhat of a safety run-in, I suppose, on this study, and that's because, right, we're giving these patients chemotherapy and radiation and immunotherapy, and so we're looking for weekly AE monitoring for the first 40 patients on each arm, just for the first 2 cycles. And then once we have confirmed that we feel comfortable with these regimens, we will drop that requirement. So it's just for the first 40 patients in each arm, but we'll let you know when we drop that. And it's if 25% or more of the first 40 evaluable patients on the experimental arm experience a grade 3 or higher colitis or other possibly immune-related toxicities, then we'll consider reevaluating the safety and feasibility of that regimen. And that was specified by the NCI. They were concerned about the safety, so we implemented this into the trial. And now Dr. Singh will talk more in depth about study procedures.
Thank you, Melissa. So we'll quickly jump into the treatment plan. As I said before, we have 3 chemotherapy options. Physicians have to inform the choice of the chemotherapy before so that we can stratify according to the subgroups. For gemcitabine, it is 27 milligram per meter square twice weekly for 6 weeks. Cisplatin is 35 milligram per meter square once a week for 6 weeks, and 5-fumaridomycin is the standard schedule day 1 through 5 and day 16 through 20. So this is important, as many CRCs can get confused when we say here day 16 to 20 of radiation therapy. This is not 16 to 20 on the treatment schedule. It is the 16 through 20th of the radiation therapy schedule. So the radiation therapy schedule is only Monday through Friday. And Saturday, Sunday is off. Radiation oncologists don't like to work on weekends. So we have Monday through Friday and then Monday through Friday on the weekends, yes. And so day 16 to 20 is the second infusion of 5-FU. And this is the standard, it should be the standard order set in EPIC or Cerner, whichever EMR do you use for this. And then for the immunotherapy arm, we are just adding immunotherapy, atezolizumab, on a standard regimen of Q21 days for 9 cycles, which is 6 months duration. The disease assessments, as Melissa said, are very critical for endpoints. So the most important disease assessment is the 18-week. This is a mandatory biopsy. Even if the cystoscopy shows no cancer, we still need to have a biopsy done to document there is no muscle invasive disease left in the space where the tumor was. So we would prefer the same urologist doing the biopsy again who had done before. And we need those slides for central review. This is very critical. We need the slides from the original diagnosis and also the follow-up. But this is the one which is critical, and it will be done. This needs to be done even if the patient signs no at the TM portion. Patients who achieve CR or only residual non-muscle invasive disease will undergo cystoscopic and cytologic monitoring for cause biopsies every 3 months for the first 2 years. There could be a situation where patients may have CIS at the time of this 18-week biopsy, and they have already they're done with the treatment. So now these patients can receive their standard of care therapy for high-grade non-muscle invasive disease. If the urologist feel that this patient had not had BCG before, then they can give BCG. Or if they think that this patient is too high risk and I have to go for radical cystectomy, it's their choice. They can take the patient for radical cystectomy at this point if they are worried that that non-invasive disease needs intervention. Or if they want to monitor that or put them on any other clinical trial, we are okay with that. They can go with any standard of care option as long as we just get the survival data up to 5 years of that patient. Patients will undergo CT or MRI of the chest, abdomen, and pelvis. The first one is 18 weeks time point where the biopsy was done, and then every 12 weeks up to the first year, and then every 6 months, the standard protocol. For every 6 months for 2 years, and then annually for 2 years. The images need to be sent by IROC, submitted to IROC via triad, and patients undergo biopsy of, if the patient undergoes a biopsy of a metastatic site. So if on a CT scan we see a lung nodule, and we don't have anything in the pelvis, and you end up doing a biopsy of the lung nodule, then we would like to have that biopsy sent to us for review if it shows metastatic urothelial carcinoma. So that is also critical. Then the other important portion of the trial is the quality of life. We are trying to engage FDA to get this on a label. If the patient meets quality of life criteria, it would be part of the label. So Ron Chen and Amit Gupta, they are leading the efforts to develop this QOL section. And there are certain questionnaires which are embedded into the trial, including EORTC C30 and BLM30, and expanded prostate cancer index and EQ5D. They have been thought of as the tests which are validated or have previous experience with bladder patients, and they will give us the insight into the quality of life of these patients after concurrent chemoradiation. So I'm going to ask Dr. Jawar to come over and talk about radiation therapy.
I just realized that in this era of acronyms, we have a new one, BIEFS. So as Dr. Singh just earlier touched upon the fact that this trial is the first ever phase 3 randomized clinical trial in bladder cancer or bladder preservation in the United States, accrual and completion of this trial is of paramount importance. And therefore, after multiple extensive discussions with all the cooperative groups involved, it was decided to keep the radiation arm or radiation therapy as generalized and as inclusive as possible without compromising any final analysis. The general schema of radiation is to deliver 64 gray in 2 gray per fraction over a total of 32 fractions given daily, Monday to Friday, or 64.8 gray in 1.8 gray per fraction over 36 fractions daily. This is to the bladder tumor or the whole bladder. Only photon treatment was allowed after discussions. 3-dimensional conformal radiation therapy with either 6 or 18 MV photons, or intensity modulated radiation therapy with 6 to 18 MV photons, or a combination of both is allowed. Multiple techniques, including tomotherapy, VMAT, rapid arc, which are now commonly used, are allowed. Proton therapy was decided after discussions to be excluded and not allowed, and neither was hypofractionation. The one decision that centers need to take up front is whether they will treat the pelvic lymph nodes or not. And if they decide, whatever they decide, they have to notify the study accrual so that this can be used as a stratification factor. Some form of image guidance is required, KV, MV, CB, daily cone beam, CTs, and then the treatment would be delivered using a CT simulation and CT-based planning on the CT data set. Simulation, planning, treatment on an empty bladder is highly encouraged, and that was a decision after the multiple discussions between different cooperative groups. So this part, that there are 2 slides, this one and this one. This first slide is where the treatment intent is to do pelvic lymph nodes along with the bladder as a cone down boost. So if you're treating pelvic lymph nodes, or including the pelvic lymph nodes either in the initial part of the radiation, the protocol describes the treatment fields in detail. So you treat the pelvic lymph nodes first using the small pelvis fields, and then you have 3 options for the cone down boost. Again, this is to be all-inclusive. You can either treat, after that, a whole bladder and then cone down further to a bladder tumor as an option A, or as an option B, you can just continue treating the whole bladder, or as option 3, you can treat just the bladder tumor after the whole pelvis. But basically, the treatment intent is to deliver 64 or 64.8 gray to that bladder tumor. If you're not treating pelvic lymph nodes, then you basically proceed with treating the whole bladder first, followed by a bladder tumor boost, or you could choose to treat the whole bladder depending on how the tumor looked initially, or you could just treat the bladder tumor alone if it was well localized, lateralized, and you're able to do that. Normal structures and constraints are also detailed in the protocol, but the main thing to note here was the small bowel. What was decided that because small bowel is of paramount importance in terms of normal organ at risk, we decided that you have to contour the bowel loops and not the bowel bag. If there are radiation therapy therapists, radiation oncologists in the room, they know what I'm talking about. And then these are the dose constraints that we basically came up as a consensus. There is no hard and fast reason as to why we picked this. We basically looked at all the literature and picked those to be basically as safe as possible. As Dr. Singh already mentioned, that radiation therapy must start within 7 days following the randomization, and the pre-treatment review of the first case on this protocol for each modality, either 3D or IMRT, has to be approved by the protocol study chairs.
Samir, I'm going to interrupt you one second.
Sure.
So it does say that the treatment has to start within 7 days of the registration, but the treatment planning can be done before. Patient can undergo the full planning for radiation treatment, and it has been decided that patient is going to get chemoradiation, and then with all that data, you then register the patient with the stratification factor. So you tell the team, ops team, that you are going to use gemcitabine, and you're going to use whole bladder and radiation, and then we will return with the randomized, so the patient is either randomized to the chemo-immuno or just the chemotherapy arm, and then the patient starts. So you can technically schedule your patient to start even before registration. For registration process, just one, the same day we can get you the information which arm the patient is going. So technically the sites should plan to start therapy before even registering the patient, because patients will be getting standard of care chemoradiation anyway. Only thing we are going to tell you is whether they are going to get immunotherapy or not, because we don't want any delays to happen after registration. This is very critical. Sorry.
No, thank you. And then if the first case has an unacceptable deviation based on their submission, then they have to require a pre-treatment review of the second case until that's the site has been approved to go further without any further reviews. That's it. Thank you.
What is the, can you show the protocol scheme again? So how much time do you get from the start of radiation to the start of chemo?
7 days. Is it 7 days, right? We give you 7 days to start, plus minus, for all treatment points.
That's from the second registration, correct?
No, from the start of radiation.
From the start of radiation.
We'll just confirm this here. Should be on the table.
So the radiation can start before the chemo?
I think it was 5 days based on what we had decided.
Plus minus. So we have a chemo or immunotherapy must be started within 4 days of the radiation, before or after. Within 4 days.
Before or after?
Correct. Within. The word is within, before or after. Yeah. Yes.
Prior IMRT credentialing that you had for other studies cannot be applied to this?
No. We have to have the first patient approved for each site before they can go on to doing their processes for the second patient. Yes. Hyung.
Yeah, are fiducial markers allowed?
Yes. Yes.
And then what's the definition of a pelvis nodal?
No, you just know if it's being recorded.
So the definition is if the physician, the investigator at the site, thinks that this is local recurrence, we will consider that as local recurrence, as long as you say that this is local recurrence. If you want to then do a fine needle aspiration to confirm it, we would need that slide or cytology. But we have left it. This was a big discussion again with FDA. How are we going to say that this is recurrence or not? So we felt that at a cooperative group setting, we cannot have a centralized review of the imaging and get the feedback back to the investigator to move forward with the treatment for the patient. So we will let the physician, but we'll be reviewing the images centrally, but at the site, you as a physician will make that call whether the patient has progressed or not. And we will not burden you with what decision you have taken. This is your clinical judgment, we'll respect that.
Is this being recorded?
Yes.
Okay, then I think people need to come up to the mics, or you need to repeat the question.
Okay. So the question was, Dr. Kim was asking, if the CT shows a lymph node in the pelvis on follow-up at 6 months, how are we going to decide whether this is recurrence or progression or not? So the answer to that question is, it will be the decision of the local investigator to decide whether the patient has progressed. And the study will perform a central review of all scans after the study has been finished, but the decisions at the local sites will be done by local investigators.
Just had a quick question. I think this is what you mentioned, but per site, one would have to pick whether or not you're doing a pelvic nodal field, right? And all the patients enrolled to that site would then follow that pathway, either bladder only or inclusion of a pelvic field.
So the question is, if the site has selected whole bladder or have selected pelvic lymph nodes, will the subsequent patients will all be going into that radiation field? Is that correct?
Correct.
No, every patient you can choose by your clinical judgment.
Okay.
If you in a patient thinks that you feel that this patient is T3, T4, and you feel that this patient has high likelihood of lymph node metastases and you want to cover the lymph nodes, all you need to do is just let us know before registration so that we can randomize, because this is a stratification factor.
Sure.
And then we'll get you the, it's your local site decision.
And a quick follow-up to that, the pelvic nodal field, is that per the RTOG
Yes.
mini pelvis methodology?
Yes.
Okay, thank you.
And it's detailed in the protocol, yeah.
Yeah, so just to add on, for that 7-day time period, it's going to be absolutely imperative that the plan be done before the patient gets randomized, because, and I want to emphasize that 3 times, because if the radiation oncologist doesn't know in advance, they won't be able to make that timeline. A lot of institutions, mine included, especially for complicated treatments, do have a 7-day requirement to go through all the QA, QC steps. So it'll be extraordinarily important for your radiation oncologist to know the day you know you're even considering them.
Correct. So is it possible?
To that same point, is
Yeah.
there, are the radiation oncologists certified in any way, or no, it's just their plan
Samir, would you like to answer?
that's certified?
I would, yeah, I mean, I think it would be.
Because our radiation oncologists don't participate in any cooperative.
So the question is, if the site has to be IROC certified before they
Right.
enroll, the answer is yes.
The radiation.
The
oncologist.
IROC, the sites have to be IROC certified before they can enroll patients on the
Yeah,
study.
we do certify the sites, so if you submitted their names to us, then they've been certified by IROC. But your question is more specific to the protocol. They have to have read the protocol, and then my question, second question, is in drawing the bowel bag versus the bowel loops, as you mentioned, you know, there are a couple of things that are a little bit not standard. If they fail the original first patient, does that delay when they can start the radiation, or do they still start them anyway, and then they just redo the plan for you? Or how are you going to manage that for violations?
So in the protocol, we actually have detailed very specifically, the bowel being the most important. We are allowing, giving bowel more importance than, and decreasing coverage up to 90%. Now, even if they don't meet, then we have to go to the second case and, you know, use that as a.
So it doesn't delay the case, it just
Right.
tells them they're not certified.
Right.
And the second part of the question is, I think you're certifying a site and then hoping doctor number 2 still does it right. Is
Yeah.
what you're saying.
Right, that was my other question, was, you know, with different radiation oncologists at different offices in communities, we see a fair bit of variation. And so one certification, is that good for all, I guess, is, and it sounds like yes.
It's going to be by NCI code, so it'll be at that
It'll be
level.
at what?
NCI code, so it's, you know how, so sometimes there's more parent sites and then kind of their children sites, I suppose. Maybe Dana can speak to this a little.
So I think that this may be something that we'll need to take a look at a little bit closer, because NCI codes can have multiple radiation sites associated with them.
Right.
And so I'm assuming that you want the plan submitted early for the radiation site, not for the registering site.
So there are so many questions right now flying. I have to, you know, I'm going to sort them out just one by one. So the first question is, Dr. Okinaf, you said that patient, let me know if I'm not correct. If the patient, if the site submits to the IROC for review of the plan, and Dr. Jawar reviews the plan and say this plan is not acceptable, and the plan comes back to the site, and patient is already scheduled to start by Friday, and this is already Tuesday, you don't have enough time to redo the plan. Can the patient start on Friday? Was that your question?
Yes.
So for that question, the idea is that they start therapy from randomization 7 days, correct? So we are not going to randomize
I might
that
make it
patient.
even more critical. So odds are the plan isn't actually done till Thursday, and the patient starts Friday. Right.
So this is important point we have to consider. If the first plan fails, submission plans, how much time do we have for them to submit the next plan to get them started? Or do their clock starts at the time of the first submission or the time when they are randomized?
The clock would start over from the second time they submit it.
Okay. So the clock will start over when they do the repeat submission. So yes, they'll have to delay the radiation till they get the approved plan.
And I assume the first plan is a deviation by that?
Would not be considered deviation. This is a step. Okay. We built in as a review process. So they submit a plan, there is a review period, we reviewed the plan and we say this plan needs these changes. Then go back, you redo the plan and you resubmit, then your clock starts there. So yes, it could be a hurdle with the first patient, but once we have a workflow identified, and correct me if I'm wrong, does dosimetrist or physicist, they do the planning or the physicians, they themselves do the planning?
The dosing mainly.
So if there could be many physicians, but the dosimetrist or the physicist should be the same in that institution, or maybe one or two. And if they have once gone through the plan, they should be able to do the plan right. This was my feeling, and I didn't want to overburden the site for every investigator to be reviewed before going on.
Oh yeah, no, I understand that. It's just that different people draw the organs at risk a little different. You know, the target will be pretty consistent, but right.
Mm-hmm. Okay. And then Dana was saying that the NCI or IROC certification, there is an NCI code for a parent site. So for example, Mayo Clinic Rochester has so many small community centers. So the Mayo code of the institution may be valid, may be covering those small community sites. Is that what you were saying?
So that is true about registering sites, but we would be capturing that information about the community sites in the database. We would know that, and presumably, I don't know exactly how you've got it set up. The problem potentially is that for each of those sites, both the parent site and the community site, they may have multiple radiation sites associated with them, not just a single radiation site. Mm-hmm. So I'm assuming you would want the approval to be based off of the radiation site, not off the registering site.
That's correct. IROC requires that. Where the machine is located, where the treatment is going to occur, there is a code attached to that location.
Mm-hmm.
There
So
is a CA code and there is an RTF, as in Radiation Therapy Facility Code. They are attached, and that's where the patient is going to be treated. That's what IROC is going to approve.
So to say it on the recording, there is an IROC code for individual site, and that particular site where the treatment is going to happen needs to be approved to go on to this trial.
right, and so you would want to, it wouldn't be a case of the registering site would then be approved from that point forward to be able to submit whatever, because if they use a different radiation facility for their second patient, that one would need to be approved as well.
So every
that
site
would
where
have
the
to be based
registration
on the
radiation occurs need to be certified by IROC. This is very critical, and we will help the sites to go through that procedures, and we'll update the sites once they're opening the trials. We'll make sure those sites have IROC certification.
And just one last point, because we're discussing about the approval process, we would need the entire plan, including the pelvis, if somebody's including the pelvis and the boost, the entire dose plan, the sum plan, to be submitted up front, and not just the initial part, because that is what, the sum plan is what will actually affect the small bowel constraints. So.
So Dr. Meeks is not here today, but I'll take over his portion. So this study is very, very important study for us. It's going to give us a lot of valuable insights on tumor biology of what is happening after radiation, chemotherapy, and immunotherapy. And in this depth of investigation has not occurred in bladder cancer in real time. This is going to be the first time, very critical, we collect these specimens. The TM portion, just as a disclosure, there has been some changes in the NCI processing of TM sections in new clinical protocols. They are asking the clinical trials to have certain volume of patients to be enrolled and tissue collected before they will approve and fund the TM portion. The TM section which we had proposed, or the planning we have proposed, have gone through the approval process, and so it will be in the protocol, but as a disclosure, at this point, we will be collecting these specimens and then showing to the NCI that we were able to do so, and then they will allow us to finally do the analysis. But no matter what, this analysis is going to happen, and we need your support for tissue collection. We are going to look at DNA damage repair response genes. We are going to look at MRE11, which have been previously shown to be associated with radiation response in bladder cancer. We will be doing neoantigen tumor mutational burden, PD-L1 staining, and also true culture on these patients. The 1605 pilot program will give us the insight on how we are able to collect true cultures from the cooperative group studies, and we are hoping that we will be able to expand that on a bigger scale on 1806. And so just to give you a little bit of background, MRE11 has been previously shown that if their tumors are high, they respond better to radiation therapy, and also we know that higher tumor mutational burden was seen to be, or the patients, tumors with high TMB had more response to atezolizumab, and that was a background rationale to look into this. And at the same time, we will be looking at molecular subtyping with luminal 2, luminal 3, luminal 4, and analyzing the responses based on the subtypes. So again, very interesting correlatives. We'll have the whole genome sequencing being incorporated into this. And so we want your support on the collection of the samples. So I'll ask Rick to come over and talk about patient perspective.
Okay, so for those of you who haven't met me, I'm Rick Bangs. I'm the SWOG bladder cancer patient advocate and a survivor of bladder cancer with a neobladder. Okay, so first, before I get into this, I just want to commend the pragmatic nature of this trial. It's really outstanding, so I appreciate all the support to make that happen. Obviously, we want to point out from a patient point of view that bladder and sexual function are preserved. We often talk about bladder preservation, but I just want to remind people that there's more to it than just the bladder. And that has been, for many of us, the holy grail. I have a neobladder. I would love to still have my bladder and my prostate. This is an underserved area, and as Dr. Singh has pointed out, we have some relatively poor compliance to neoadjuvant chemotherapy as the standard of care. It does, however, require some level of bladder function, all right, and so we have to take that into account. Keeping your bladder is a nice thing, but you want to have a decent functioning bladder at the same time. Tumor probably should be in quotes here. The tumor is not being completely removed. There's always the possibility of residual tumor or CIS and so forth. We have to keep that in mind. The success rate on immunotherapy is relatively low. It's not as high as we'd like it to be, but we're building on the chemoradiation, so this is versus a pure immunotherapy trial. The success rate should be a little bit higher. The safety of immune checkpoint inhibitors in combination with chemoradiation plus the side effects are things to keep in mind, things that patients might be concerned about. The radiation can have an impact on your urinary diversion choice, and that is important for many of us. There is, as is true of most treatments, logistical and financial burden associated with the trial. And we have a very important but new endpoint, and that is something that's exciting to see as a survivor. On that, I will turn it over to the next person.
Thank you. So is Elaine here?
Okay. I'm Elaine Armstrong. I'm the Quality Assurance Manager, and I oversee the audit program. So we're kind of a little out of order here. Donna's going to talk about central monitoring after I talk about the on-site monitoring. So, you know, the purpose of the Quality Assurance Audit Program is to verify that you're compliant with regulatory and protocol requirements, make sure that you're adherent to the policies from the NCI and SWOG, and make sure that the data that is being reported is accurately reflects what's in the source documents. And it's especially an opportunity for us to provide educational support. I know sites really look forward to audits at times, and so it's very helpful to have somebody there to look at your data one-on-one. So during the normal audit process, we do routine audits every 3 years, and we look at 10% of your accrual. And this accrual would include your SWOG, CTSU, cancer control accrual, and then there's monitoring of SAEs that's done independently off-site. So what's different for 1806? Well, the first thing is that there's mandatory training of key site personnel prior to your first patient registration, which is what this is. However, there could be additional mandatory training, you know, that will be available online to the sites. Sometimes it's because there's major changes to the protocol. If we were to, say, come on a visit to your site and find out there were a lot of gaps in knowledge, then we might require that people to go through additional training. Then there's off-site centralized monitoring of the first 2 patients per site, which Donna will talk about. And then we also do more frequent. We just come quicker and more frequently on these registration studies than we do for regular routine audits. Some of the other things that you're required to do for this study is you will have to have a trial master file. There will be a delegation of task log. And then there's just a whole lot more communication, you know, between the study team, whether it's study chair, the statisticians, the data coordinators, the monitors. We try to, you know, share information so that we can give you feedback and, you know, kind of get you notified up front, you know, where there's potential problems. So the first visit to your site will be within 6 months of your first patient randomization. And then subsequent visits will be either after 1 or 2 years, depending on your accrual, but at no less than every 2 years. And then if you're, you know, when you're SWOG sites, then we will oftentimes try to pair these types of visits up. If we're going to be at your site for a treatment audit, we may, you know, and you're due for an 1806 monitoring visit, we may bump it up a little earlier, a little bit later, just so that we can bring them, you know, do them at the same time, because I know it's easier on the staff if, you know, we take care of everything at one time. So some of the reasons for having more frequent on-site monitoring than even what's in the schedule would be is if you had an unacceptable audit, then we would, you know, have to schedule a re-audit. If we find problems that might not even affect then the central monitoring, if Donna brings it to our attention that, oh, you know, the first 2 patients that we looked at had, you know, some issues, then we might schedule additional monitoring or go sooner than the 6 months that we had planned. If you have a lot of delinquent data, or they're finding a lot of data submission errors, that might prompt an extra visit. If there are a higher number of SAEs than expected at your site, or if there are, you know, more ineligible patients. And then if we find out that you've had complete staff turnover where maybe, you know, we need some one-on-one education, that might prompt an extra visit. So then what to expect when we're there, you know, if you've been through an audit, it's kind of the routine things. There's going to be the regulatory audit, that in addition to looking at your IRB approvals and your consent form content, we'll also be verifying that you have your trial master file set up and that you have a delegation of task log. Then there's the pharmacy review, where we will look at drug accountability records and go visit the pharmacy. And then during the patient case review, the routine of looking at the consent forms, eligibility, treatment, disease assessment, toxicity assessments, and data quality. So your responsibility before you have a site visit is that we really ask that the records be organized and flagged. Trying to get through, a massive amount of data is very difficult if you haven't flagged things, say, by cycle number, that sort of thing. More and more frequently, we have sites that want us to audit directly in your EMR. We can do that. We do have expectations, that you have somebody available to help us, to work our way through your system. Usually once we've done done the first chart, then we're okay. Occasionally there are special requirements for a password, so you need to make sure that's all set up. It's very frustrating to get to a site and have to sit there for 2 hours because somebody forgot to get us passwords, and so then we can't get into the EMR. It's real important that you schedule a time to visit the pharmacy. Some places it's a real informal thing. It may be in your office, whereas other times your pharmacists are very busy and they want you to schedule something in advance at a specific time. You need to have staff available to help us and answer our questions. They don't necessarily have to be with us every minute, but available throughout the day. And then we will have an exit interview where we go over all of our findings with preferable, with any of the staff that are involved and your PI if possible. So on the QA page of the SWOG website, there are a lot of resources. There's the QA policy, the QA audit guidelines. There's a link to the NCI monitoring guidelines. There's a lot of information on regulatory guidance and information on FDA inspections, and including the trauma master file. And then I'm basically your main contact if you have questions. And because I knew there might not be enough time, did you get your handout on investigator responsibilities? I assume that was handed out to you. But there's a lot of details in there about what is expected for the trial master file. And, and then the delegation of task log. Right now, we require sites to have a paper log. I haven't gotten 100% confirmation from the NCI yet on, but usually they require there to be an electronic delegation of task log that you would fill out through the CTSU website. If you've participated in 1418 or 1605, you would have already been through that process. But they had not been able, as of today, to confirm with me that they were gonna, it's like a pilot project doing the electronic version, so I'm gonna work off the assumption you will have to have one, but I just can't confirm that yet. And then Donna's gonna talk to you about the central monitoring.
Okay, so basically, I just wanted to talk to you a little bit about, we're considering it the risk-based monitoring for 1806. How many of you have participated in the 1605? Anyone here? Okay. So I'm not sure if your site has gotten the central monitoring notification that you've got a couple of patients that you need to do. But I did want to introduce Monica Chioki. She's way in the back over there. Just put your hand up so people can see you. So she will actually be doing the central monitoring for 1605 and also this study, 1806. And like Elaine said, that the FDA does require more monitoring for the registration trials. And so that's where the central monitoring does come in as well. And so we are working with the auditors. We're supporting the auditors, but we're in different locations and different roles. And so we're at the Statistical Center, the Statistics and Data Management Center, and we're in Seattle, and Elaine is out of in San Antonio at the operations office. So, but we do work together in conducting, and basically the central monitors, though the different role is that we're actually conducting the source doc verification. So we're just reviewing the source docs that you're uploading. And the head CRA, how we are doing this right now is the head CRA will be notified by Monica, and she'll be contacting the head CRAs with the instructions on how to upload all the documents. 1605 was a pilot for the the CTSU portal, which I'll be going into a little bit more in a few minutes. But so there are different instructions and different ways of uploading documents. For the first 2 patients randomized to each treatment, Monica would be contacting you. And some of these are the elements that we're looking at. I provided a handout, which hopefully you all received. It has a lot more details in it. For timing for today, I just wanted to let you know what we're going to actually be looking at. But it'll be for, you'll be uploading documents for supporting eligibility criteria, consent process and the actual consent, activities for cycles 1 and 2. And then we're also going to be looking at the disease assessment at week 18 and the quality of life questionnaires from week 12 and 18. And then this is a slide that basically shows you the 2 ways to get to the portal. You have access to the portal via a link in Rave. So my suggestion would be to go ahead and submit all of your data that you're going to be doing in Rave first. And then there will be a notification in Rave, which is the second, oh no, it's in my next slide, so let me just go to that one. So basically the first one is accessing, go ahead and go into Rave to submit all of your data first. And we're not asking for you to upload any documents in the portal that you've already uploaded in Rave. So like for the op and path report that's in section, I think basically section 14 tells you to upload certain documents. We're going to actually be reviewing, we're going to go into Rave and review those and not ask you to upload any of the additional things that we need into Rave, into the portal. And so I think this is probably a little bit too hard to read from back there, but basically you're going to enter in all the data. There's a notification that tells you that these 2 patients, when you go into Rave, are identified for the central monitoring. And then there's the link that you can go directly to the portal. If you choose to go directly to the portal to upload the documents, you can go to and then you just go to the auditing and monitoring, and then you just follow that to the source doc portal, and you're right there. The benefits of doing the source doc uploads in the portal is that they have a redacting tool for you so that you can use it and redact it, and it also pre-populates the patient ID number so that, because it's already knowing that you're there. So those are 2 benefits for actually uploading into the source document portal. And one other thing is just to kind of give you a feeling of why we're doing it, why this portal was developed, is that Rave was never built for uploading documents. And so I don't know if it's actually a space issue, of not having enough space with the Rave system. But so CTSU actually developed this for us for doing the uploads. And the future is probably going to be that most uploads will be in the portal as well, not just the registration trials. And then I just also wanted to explain that at the Statistical Center, I always say the Statistical Center, but I'm supposed to be saying our big long name now, so it's Statistics and Data Management Center. I just wanted to explain also what the role of the data coordinator review is. So we've got the audit team, we've got central monitoring, and we also have the data coordinator review. And they're reviewing all data. So they basically, not just the first 2 patients, so they're looking at all the data. And they do look at the source documents that are uploaded in Rave, but they're not going into the portal and looking at all the other data that's being submitted. And so they verify the source let's see. I forgot where I was at here. So they're looking at the op and path reports and all radiology reports and scans performed to assess the disease at baseline, and in section 14.4 I and J. They're looking at the path report the path reports for the mandatory biopsy, the cystoscopy report, urine cytology report, radiology reports from all the scans performed to do the disease assessment. They are looking at the site characteristics and performance metrics to identify the trial sites with poor performance or non-compliance through the SWOG IPR and other available reports. And they're looking at the timeliness of SAE reporting and the timeliness of the data submission. And they do verify the specimen submission. So you are being monitored actually by quite a few individuals at both the operations office and the stat center. And this is my contact information. You're welcome to contact me if you have any questions about the monitoring. And I think in your handout, it also has the link for central monitoring in general, so you'll get anybody that's doing central monitoring on that. So any questions for Elaine or myself? Quiet group.